Well, good morning and good afternoon, good evening to you all, wherever you are in the world, and welcome to this fantastic webinar, a collaboration between Nursing Now Challenge and the World Health Organization. I'm just going to take a little time for everybody to jump on the call, settle in, and get their seats. We've got a fantastic hour ahead, and I'm particularly grateful for all of you who have got out of bed early or going to bed late from wherever you are in the world to join us. I am really glad that you did. This is a massively important issue, and we are delighted that we're going to be able to do something to support the work around it. So I think we will start, hoping that everybody's managed to join. We're delighted to launch this new global solutions today. We really hope it's going to be the start of something really big that will make a real difference to the important work going on to tackle antimicrobial resistance. Over the next hour, we're going to hear firstly from our Chief Nursing Officer at the WHO, Elizabeth Iro. Thank you for joining us, Elizabeth. Elizabeth is no stranger to you and has been a huge supporter of the Nursing Now campaign and the Nursing Now Challenge, and more importantly, a real advocate for the development of nurses and midwives in the early parts of their careers. Elizabeth has talked widely about how we strengthen nursing in midwifery by working together and by sharing our expertise and stories and our experiences. And this is the perfect opportunity to put our heads together and find solutions together for our global health challenges. So welcome, Elizabeth. We're then going to pass over to our colleagues and friends in the antimicrobial resistance team at the WHO. This is a truly inspirational team with energy and passion, and we are definitely going to hear bucket loads of that today from them. So thank you so much for joining us too. Over the course of the next 3 months, we have more time to hear from them all, and you'll have the opportunity to ask more questions about the important work that they're doing and how what we're asking you to do can align with that work. So after we've heard from them, it'll be over to you. So I really ask that you have questions and comments for our team today. Please write them in the chat box, and we'll have some time to put your questions to them and to ask so that we can ask the questions that you want to know the answers to. After that, I'm going to explain the process around taking part in this challenge. I'm going to highlight the events that we're hosting over the next few months. We've got several and they're brilliant. What we're going to ask you to do, we're going to talk about the challenge itself, and we'll talk about where you can find resources and information that will help you. And then we're going to talk about the award. This is a challenge and we will have a winner. We want to talk about the winning solution, and we'll discuss that process for you. We'll also talk about the prize and the award that will mean. So I think hopefully everybody's managed to join. I hope you're all sitting comfortably. And moving on, I'm really delighted to introduce Elizabeth Iro, our chief nurse, live from her home in the beautiful Cook Islands. So Elizabeth, over to you.
Thank you. Thank you very much, Emily. Really great to be able to participate tonight. Good morning and good evening, colleagues and friends that are able to join us for this event. Thank you so much for joining us today. It's wonderful to see so many of you able to join us. I am really delighted that the World Health Organization and the Nursing Now Challenge have come together to support a Nursing Now global challenge. Our strength to tackle some of the greatest problems in global health lies in our ability to work together, to share our knowledge, and to learn from each other. As healthcare professionals, we have a huge responsibility to prevent and control the spread of antibiotic resistance. Today, we are here to find solutions to tackle one of the greatest threats to our global health that we are facing. And I do not say this lightly. The COVID-19 pandemic has dominated our world now for over 2 years. It has resulted in the deaths of over 5.9 million people. It has been catastrophic for the global economy, and I do not believe there is a single person in the world who has not been affected by its impact. However, in 2 years, we have been able to develop effective vaccines. We have been able to mobilize the entire world to deliver and vaccinate our global population of almost 8 million people, vast populations in huge cities and small communities in rural and remote areas. Although this has not been easy, and it is far from over, we know that we have the ability the brains and the technology to bring this pandemic to an end. Antimicrobial resistance is a very different issue. Its effects on our health will become a global problem, far worse than the pandemic, if we do not address the issues now. The overuse of antibiotics is threatening our ability to treat common infectious diseases such as pneumonia, tuberculosis, blood poisoning, gonorrhea, and foodborne diseases. These diseases are becoming harder and sometimes impossible to treat as antibiotics become less effective. Are we prepared to imagine a world where people die of simple diseases or minor injuries because the incredible medicines that we have relied on since the discovery in 1928 are no longer effective? This challenge is reaching out to you. We need your support and we need your help. We are asking you to develop a solution that tackles the misuse and overuse of antibiotics. I know from my experiences talking with you in the past, from listening to your inspiring stories, and from learning from the way you approach challenges and problems, that you will have great ideas. I know you will suggest innovative solutions that we can use to help us tackle this serious problem. And I know you will step up to this challenge with the enthusiasm and energy that it needs. I'm really excited to hear your ideas and to work with you to turn these ideas into solutions. Together with our team of experts at WHO, I'm really looking forward to the next 4 months as we focus more on sharing our knowledge on AMR and discussing the ways nurses and midwives can make a real difference. Your experiences are really important and we want to hear them. Your views matter to us and you need to share them. Most of all, we need to work together to tackle this huge agenda. I know we can achieve big things with this challenge, and I sincerely thank you for taking part. Thank you. Thank you, Emily.
Thank you so much, Elizabeth. Really, really important words. I really hope that you have heard them and that you are really excited about what you might be able to achieve, because we really do need your help. I'm going to now introduce you to the legend that is Dr. Leanne Gonzalez. Leanne is the Technical Officer for Antimicrobial Awareness and campaigns in WHO's AMR division. Leanne, I'm going to go straight to you. I know you've got some fantastic things to show us and to share with us. So thank you very much for joining us.
Thank you, Emily, and you're far too kind. It's been a pleasure working with your offices and with Elizabeth. I'm going to go ahead and introduce our Assistant Director General, but before I do, as a bit of a primer and a way to switch things up in this session, we're going to actually start off with a video that's going to give everyone joining us today a bit of background on the complex but incredibly important issue that is antimicrobial resistance. And we're going to show you a 5-minute video that was actually submitted as a part of WHO's Health for All Film Festival in 2020. The film is succinctly titled Antibiotic Resistance and actually won the student prize as part of the film festival. So Emily, if I can ask you to go ahead and share the video, we'll start off with that.
We tend to think about ourselves as humans, but this is only partly true. We are composed of trillions of human cells, but we are also made up of trillions of bacteria. These bacteria are part of us. They cover our entire skin and guts. Bacteria help us digest the food that we eat and protect us from intruders. But some bacteria have the potential to be harmful, causing diseases that risk human life and bring about suffering. So humans discovered antibiotics, and for a time, it was good. Antibiotics are produced by fungi and bacteria in nature, and were adapted by humans to be used as a medicine. Antibiotics are unlike most other medicines. They do not affect the activity of human cells. When exposed to antibiotics, only the bacteria die, while the human cells remain unharmed and the disease is cured. Antibiotics made once deadly diseases as harmless as having a cold. They have enabled many of the improvements in modern medicine, such as safe invasive surgeries and transplants. But look, some bacteria survived the antibiotic treatment. How did that happen? Let's look back. In the very beginning, even before the antibiotic exposure, some bacteria were already different. These bacteria had a resistance gene that protected the bacteria from the antibiotic. So, when the antibiotic was introduced, it did not kill the bacteria that had this gene. Instead, they survived. This is what we call antibiotic resistance, the resistance of some bacteria to antibiotics. But where did this resistance gene come from? How was this resistance gene there, even before the bacteria were exposed to antibiotics? Each time bacteria divide, their DNA undergoes random mutations. Most of these mutations are neutral or unrelated to antibiotics at all. But very rarely, one of these mutations can accidentally result in a resistance gene. Bacteria can also swap genes between themselves. Most of the time, these genes are not related to antibiotics at all. But very rarely, bacteria swap a resistance gene. Even though it is random and happens very rarely, because there are so many bacteria in the world, and because they divide so fast, every hour or less, for each antibiotic we create, there is already a resistance gene out there. What's more, because bacteria swap genes so frequently, this resistance gene can reach by chance disease-causing bacteria, making these diseases much harder to cure. These resistance genes appear and spread randomly, but each time we use antibiotics, we make these rare random events much more significant. The antibiotic kills most of the sensitive bacteria, leaving the resistant bacteria to survive and multiply, so their proportions in the population increase. This is what we call evolution of antibiotic resistance. These resistant bacteria can easily spread in the environment. So each time humans use antibiotics, resistant strains become more and more prevalent everywhere. How can we change this? We can use our growing knowledge about bacteria to make new drugs. These drugs could, for example, prevent harmful bacteria from causing a disease, but without killing them. So even when resistance to the drug appears, the resistant bacteria will not have an advantage compared to the sensitive ones, because all bacteria would have similar chances to survive and multiply. So the proportions of the drug-resistant bacteria will remain low. But what can we do now? We need to change the way we use antibiotics to limit their use to only when it is absolutely needed and in a minimal amount, so we can slow down the rise of resistant bacteria until new discoveries will come.
I hope you enjoyed that brief primer. You'll get to hear more about antibiotic and antimicrobial resistance more broadly from the woman who is leading the division at WHO. It is now my pleasure to introduce you all to Professor Hanan Balkhi, who is WHO's first appointed Assistant Director General for the Antimicrobial Resistance Division, which itself is a flagship program for the WHO with a mandate to lead the human health response to the emergence of antimicrobial resistance along with relevant stakeholders. Dr. Balkhi is a professor of pediatric infectious diseases with over 2 decades of experience in the field of infectious diseases and infection prevention and control, which many of you know as IPC. And she is a clinician and a researcher as well. She has led a WHO collaborating center for IPC and AMR. established the Infectious Disease Research Unit at the King Abdullah International Medical Research Center, and was also the editor-in-chief of the Journal of Infection and Public Health for 10 years. With that introduction, I'm delighted to hand over the floor to you, Hanan.
Dear Leanne, thank you very much. Thank you, Emily. I would like to start by thanking the Nursing Now Challenge, including Professor Lisa Pratt and Hannah Finch, who coordinated this challenge. My sincere thanks also goes to my sister Elizabeth Iro, our Chief Nurse Officer, for the invitation to be part of this initiative and for her continuous collaboration on critical issues, including the AMR. I think the video, just a brief introduction, I think the video kind of set the stage of what we're trying to face. We're facing a very active group of pathogens that some of them live on our bodies and are useful to us, but some of them can cause significant harm. Again, from my vast experience as a clinician at the bedside, I have the utmost and huge respect for the nursing as a discipline. And I think over my 20 years as an infectious disease, but since medical school, it's now been maybe closer to 30 years, difficult to say, but working alongside the nursing and the midwifery discipline is extremely, it's a privilege. They are considered the backbone of the healthcare system. And I think this event was something I was very much looking forward to because I know that it was delayed a few times because of COVID and the pandemic. So it's my true honor to be among you all today and to share some of my experience and maybe some of the thoughts, but also to hear questions from you on how we can better move forward from your side, because as nurses and midwiferys, I'm pretty sure that you already have so many ideas and so many critiques to what takes place specifically on the wards. In establishing the AMR working group at my previous hospital, I had a core of our chief and leader nurses within the organization, and I can confess that I learned more from them than what they have learned from me. What I do want to say before I hand it back to Leanne is that the antimicrobial resistance is a mouthful. It's more sometimes it goes beyond the walls of the healthcare setting and the communities for human health. It is really a very complex topic, which is relevant to the lives and livelihoods of humans, animals, plants. The incentives for the bacteria to want to change from being susceptible to resistant to an antibiotic is their basic need to survive. Bacteria want to do nothing but to multiply. So once they are under the pressure and exposure of antimicrobials or antibiotics, whether in the humans, whether in the environment, whether in the animal, they try to come up with clever ways by expressing suppressed genetic pieces that allow them to change their outer shape or face so that they will no longer respond to the antibiotic, but also bacteria let loose in the community, in the environment, and within humans and animals can exchange genetic material, and they cheat from each other on new genetic material. Some of them are called plasmids. I call them time bombs. They're like They're like cassettes of genetic material that can carry innovative and new ways of resisting antibiotics. So when they are exposed to the antibiotic the next time and the third time and the fifth time, they are no longer killed or paralyzed by these antibiotics. So again, it's very complex. I'm happy to answer questions in relation to what I had just mentioned, but I also want to make you aware of the global burden of disease data that came out on the 22nd of January of this year, where IHME, or the International Health Metrics Institute, was able to produce a paper that looked into the global burden of disease from antimicrobial resistance. And the numbers, to me, I have to confess, they were not super shocking. I still think they're an underestimate. But in 2019, 5 million deaths associated with antimicrobial resistance, and 1.3 million deaths attributed to antimicrobial resistance, with 6 or 7 pathogens on the top, or causing around 70% of those deaths. So we definitely need creative solutions, not only within the healthcare setting, not only from this amazing group of health discipline, but we need to do much more. And I think that's where I'm at this position. I went from the bedside as a clinician and a researcher to leading the antimicrobial or the AMR division at WHO, made by Dr. Tedros as a cross-cutting flagship program, where I can work with many of the different relevant units. Elizabeth and her team is one of the more critical ones for us, but also with the immunization programs, infection prevention and control, WASH, antimicrobial stewardship, patient safety, quality control, and it goes on and on. It is important that you also realize that at country level, since 2015 and since the release of the AMR Global Action Plan, WHO has been working quite heavily with our member states, 194, to ensure that they are capable of producing their customized national action plans that are based on 5 main pillars elaborated in the Global Action Plan. These are national action plans that are expected to be multi-sectoral, that bring together the different sectors, definitely including the human health, but also the animal, agriculture, plant, water, and it also has an arm on the need for research and development. So that's basically what I do. The challenges on the ground for each of the countries are vast. They range from the lack of awareness and the politicians, the financial support that is needed for establishing the programs. Sometimes they're not aware of the complexity of the situation, and there's also a significant lack of expertise in many of the countries, and there's also lack of resources to sustain some of the important interventions such as PPE, alcohol hand gel, proper and effective antimicrobials, and the expertise to develop guidelines and guidance that are customized to not only the national level, but then it has to be customized at the healthcare system level. One of the critical roles that I can see that is needed always by the nursing midwifery discipline of healthcare providers is definitely their techniques in caring for patients, and their collaboration with the rest of the medical team at the bedside to ensure that proper diagnosis and management are taking place, that the patients spend the least amount of time at the healthcare setting, that they have the least amount of interventions, and they do not receive interventions that are not necessary, to the simplicity as an intravenous peripheral IV, all the way to medications, including antimicrobials. Post-op patient mobilization is a good example. The more you mobilize, the quicker you mobilize a patient after surgery, the less likely they will stay in the hospital, the less likely they will acquire an infection. And there are many examples that I'm happy to address as we move on. With that, I'd like to stop here for this. Maybe, I hope it wasn't too long, but back to you, Leanne.
Thank you, Hanan. I'm actually wondering if I can probe a more personal question for you. You know, you come from, you were a pediatrician for over 20 years, and you, in our discussions that we've had one-on-one, and I've heard you before, you know, IPC has always been a very core part of your own story. And so I'm wondering, since we have a lot of early career folks who are tuning in, if you could talk a little bit about your own transition as a pediatrician, what got you interested in infection prevention and control, what got you interested in AMR, and kind of led you on this long path to now being, you know, ADG of a new division.
Thank you, Leanne. So yes, as a pediatrician, I was very passionate about the properly diagnosing my patients. I think my mentors had taught me that that was extremely critical. And when you talk about proper diagnosis, it means that you're very keen on proper treatment. And that is one of the core pieces that are missing that lead to antimicrobial resistance. If you're not capable of diagnosing a patient, you need to shoot in the dark and maybe provide unnecessary therapy and treatment. Knowing what your patient has is critical in proper management and also in avoiding unnecessary interventions that can potentially do harm. When I finished pediatrics, I was keen on subspecializing, and I was inspired. I'll just say this: I was inspired by one of my mentors as the infectious disease doctor. Mark Pasternak is his name at Mass General, and he told me that, it's interesting, Hanan, that this specialty, they pay us to think. They pay the infectious disease subspecialist to think for the overall dilemma that the patient is in, because as an infectious disease specialist, you have to probe into detailed history, detailed physical exam, and assessing the patient. After getting into the field of infectious diseases, I attended one infection control committee meeting by coincidence with another mentor at Case Western Reserve. And we were in the middle of rounding on very, very sick patients. And he said, we need to go to this IPC meeting. And I had no idea what was going on. It was a room full of these amazing nurses. The infectious disease doctor, my mentor at the time, was silent. They ran the show. They did all the talking. They were talking about these signs that need to go on the door that says contact precaution, that says droplet precaution. And then when we left, I'm like, Phil, what was all that about? What is that? He says, oh, no, that's the infection control committee. I'm like, oh, what do they do? So you can imagine how ambivalent some of the physicians, and I was in infectious disease subspecialty training, we were not aware, or we're not made aware of the huge role that the nursing staff takes care of when it comes to infection prevention and control. And then I went back to Saudi Arabia, my original country, and by coincidence, again, the person who was leading the infection control program inherited to me. Dr. Khan was his name. He was retiring, and he said, Hanan, you need to do this. And I'm like, I don't know anything about IPC. So since then, this was 1999. Since then, he gave me a very small unit, and I just started reading and understanding and reflecting. And then I took the CIC course. And ever since then, I realized the difference from going from a bedside one-on-one patient treatment to going to a bigger picture at the healthcare environment, understanding why do patients develop surgical site infections? Why do ICU patients develop ventilator-associated pneumonias? Why do pregnant women giving birth and having C-section develop a surgical site infection? So those things, and knowing at the same time that this is not okay. This is harm inflicted on the patient. So then a lot of terminologies came out from patient safety, quality care, but at the core of all of this was, how do you put in place programs that understand the environment beyond the patient, from the healthcare provider to the visitor, to the sitter, to the patient's own issues, to the room of the patient, to the ventilation, to the laundry, to the food services. Everything around the patient might play a role in the patient developing infection. Now, when those infections happen in the healthcare setting, they're going to get really strong antibiotics most of the time. That perpetuates the whole AMR issue. Patients, there are studies showing that patients released from the hospitals going into the communities can be now colonized with resistant pathogens. They share it with their families and friends, unknowingly, of course. Patients get admitted again, and the cycle continues to perpetuate. So that goes on and on and on and on. And there's a lot of more intricacies within the healthcare environment. But just to not totally omit the issue that I deal with at WHO, which is AMR, and I also became more aware of it here, is the lack of access to antibiotics. It's something that we always have to say within the same breath. We worry about misuse of antibiotics and MDROs, multi-drug resistant organisms, but we also very much worry about the many hundreds or thousands of children and women and patients that can potentially die because they do not have access to the right diagnosis or to the effective, affordable antibiotic.
Thank you, Hanan. We've got a couple of questions that have come in from the Q&A that I'm hoping you can maybe briefly answer. We've got a question from Rahul Sharma that says, does stopping a course of antibiotics early lead to antibiotic resistance? And then I'll give you both the questions that we've received, actually, from Salim Al-Kandari, who says, a question with regards to the use of surface disinfectant and development of microbial resistance. Is there a relation?
Two really great questions. The first one, in that beautiful video that you showed, as I said, if you think of how does the bacteria think? The bacteria wants to survive. So antibiotics are divided into two big categories: antibiotics that kill the bacteria and antibiotics that paralyze them or stop them from multiplying. So we call them bactericidal or bacteriostatic. So when the patient or when the group of pathogens or bacteria are exposed to the antibiotic and you don't kill them off, so they're still alive, and when the pressure of the antibiotic is gone, they will start multiplying again. But because of that hit, some of their already programmed genetic material becomes expressed. So even in the next exposure to that same antibiotic, they won't even be paralyzed. They will continue to multiply. So the biggest rationale of not stopping a course before you're supposed to, it's because you want to ensure that the bacteria were killed off totally, and you did not give them a chance to be somewhat. Some of them are killed off, but some of them are not. And that is not just by continuing the use of antibiotics for the prescribed time, but also for the prescribers to ensure that they prescribe the right dose. So you can, there are scenarios where the doctor gives an inaccurate dose, a lower dose, for 7 days. The patient takes it for 7 days, but because the prescription was inaccurate, then the risk of developing resistance happens. That's why the right medication for the right bacteria, the right dose, the right route, the right duration, and stopping it when you're expected to stop it is critical. On the question for disinfectants, the disinfectants are extremely important for maintaining the hygiene of the hospital environment. There are studies that are coming out looking into resistance developing to some of the phenolics or to some of the alcohols, which is used also for sometimes the environment, but also for hand rub. But those studies are still limited, I think, at the moment. And the proper disinfection policy and procedures need to be followed accordingly within the healthcare setting. So they are important.
Thank you for that, Hanan. I've got a couple more questions for you, if that's okay. You've got someone who posted in the chat mentioning, the importance of reducing hospital stays for the patient to avoid hospital-acquired infections. Recommendations about how to address this? Do you have any magic ideas?
Excellent. Yeah, great question. Great question. That is, maybe I alluded to it a little bit. Hospitals in some communities are considered like a social gathering place. People like to go to the hospital. Some places, they get better food there. They can have their visitors of their relatives there. Some people like to go to the hospital. What we need to understand is that hospitals are not for healthy people. We don't want healthy people to be in there, and we want the sick people to be in there for as short as a time as possible. An example is your post-surgical patients. You need to mobilize your patients. So first of all, they don't develop DVTs, deep venous thromboses, that they don't stay in the hospital longer than they need to so that they can mobilize. The different disciplines, for example, intensive care science has advanced significantly in even how do they do sitting up ventilation? How do they mobilize the patient while they're on the ventilator? How do you wean the patient off of sedation early on so they can be mobilized? I think the magic wand is, first of all, to ensure that you're giving your patient the right treatment, that I'll say very simple things and people might think that this is silly, but this is the reality. The doctors need to be rounding on their patients every day to ensure that they discharge them on time. There are patients that are forgotten in the hospital sometimes, that they're staying there unnecessarily because the medical teams are overwhelmed or they have not discharged them because the prescription of the discharge medications has not taken place. So that efficiency in taking care of the patient is important. The other thing that goes beyond that is the support that the healthcare system needs to extend the arm of healthcare in the patient's house. How do we create, for example, home IV therapy programs? How do we create physiotherapy at the home? For example, my mother had bilateral knee replacements. She left the operating room and she was already having her knees in these weird machines that were mobilizing her. And then within 24 hours, she was moved into a rehabilitation unit, which was less intense than the hospital. And very quickly, she was moved out into the community. So she stays as minimum as possible. This might reflect a little bit more on high-income countries and countries with major resources. In mid-low-income countries, this becomes a big challenge, especially with the lack of resources. I think what is important is to ensure that patients do not necessarily receive what they do not need. So quality of care becomes very important to keep these patients outside of the healthcare setting. Outreach programs are important. If we want to talk about why do patients go into a hospital within a specific community, how can preventive programs improve that? That will take a long time. So in communities where diabetes is extremely high, diabetes and the ramifications of diabetes are quite horrific, and they cause a lot of admissions. Renal failure, the same. Obesity, the same. It becomes a little bit more complex with oncology patients, and so on and so forth. So I'll stop here and see if anybody has any follow-ups on that.
Yeah, and I do want to encourage if any of the attendees have questions either for Hanan or Elizabeth, to please feel free to add them into the Q&A. We've been able to address all of those that have come so far. Hanan, I have one very quick question for you before we, as people are perhaps adding theirs. I think you've mentioned the importance of health teams and working with different parts of like a multidisciplinary team as well. And I feel like stewardship, for people who are doing the challenge, the idea of antimicrobial stewardship is something that they're going to hear quite a bit about. So can you just describe briefly, even from your own perspective, like what is antimicrobial stewardship and how do nurses in particular really slot into that?
Wonderful question. Yes. So stewardship is just how do we sustain the effectiveness of antimicrobials? And if you look at the very early papers describing stewardship, they go beyond the proper use of antimicrobials. They go into the holistic programs of IPC, of infection prevention and control, proper hygiene of the environment, the laundry perspective, the housekeeping perspective, the HVAC perspective, all of the whole environment of the patient. Because if we want to preserve antimicrobials for a longer period of time, we need to eliminate all of the reasons that will cause the patient to get sick where you need to use an antimicrobial agent. Because once you decide to use an antimicrobial agent, there's a possibility of it being used correctly or incorrectly or for a longer period of time. So as much as we can in stopping the emergence of infections in the healthcare system or in the community in general, the better we would be off. The other way of looking at antimicrobial stewardship, which would be the proper use of antimicrobials, and that is also quite a complex entity, which I've worked for many years trying to establish the own. So if a prescriber wants to give the proper antibiotic, they need to have a good laboratory system that can identify the bacteria. So you're talking about a robust laboratory system that can identify and provide you with susceptibilities and sensitivities of the specific pathogen. The prescriber needs to have a decent formulary that has the options. And as you know, there's the aware list, where if the physician only has one option of a very broad spectrum, a very powerful antibiotic, then he or she will not be able to give the right antibiotic and will use a stronger one, which will allow for more resistance. So having the right formulary, having the right supply chain, having the effective antimicrobials that are not counterfeit, all of these entities are crucial in making sure that the prescriber knows what to do and has the tools to execute what needs to be done for the best of the patient, where antimicrobial resistance does not rise as a byproduct of the lack of all of these commodities.
Thanks, Hanan. Emily, I see you've come on. Or do you have anything to add or other questions to pose? Thank you to those who are chiming in the chat as well.
Yeah, no, thank you. There's some great questions coming out, and it's really nice to see. I would like to ask you a question. Yes, Professor Bulkley, just in light of the fact that something that Elizabeth raised earlier on about the COVID-19 pandemic, and what are the lessons that we have learned from that that we need to bring into our work around AMR. And I wonder whether you might just be able to give that an insight for nurses and how we need to be learning about what we need to be doing differently.
Thank you so much. There's so many lessons, but let me try to focus on one or two. The first thing that we saw during the COVID pandemic at the very early days with the extremely overcrowded hospitals was almost giving me heart attacks on a daily basis, because as much as you saw those patients crowdedness in the corridors and almost on top of each other, and the whole discussion was about COVID, you know that within that environment, the transmission and sharing of bacteria was taking place to a very significant degree. Healthcare providers were trying their best to do what they can, but I can assure that it would be very, very difficult for them to have prevented the transmission of bacteria in that environment. We would like to see more studies, and I know that there are several institutions that are looking into that to see the impact of this crowdedness and the COVID, especially at the very beginning of the pandemic, and how did that increase antimicrobial resistance within those healthcare settings. So that's one that we need to pay attention to, having policies. Of course, this pandemic is above and beyond anybody's imagination. I've never faced anything like that, although I've been talking about the next flu pandemic for my whole career, trying to warn people, but I never expected to live this. We do have an infection prevention and control, and many of the accreditation programs ask for a policy within the healthcare setting in the case of a surge of respiratory diseases, because we know when there's a new pathogen or a nasty influenza season, we're going to be seeing a lot of patients. We need to know how to manage them within the healthcare system so that they can actually be managed well. The other thing that the COVID, with the drive of the use of antimicrobials is always expected with the respiratory seasons, because many communities don't have the diagnostics to decide before giving the antibiotic, oh, is it influenza? Is it RSV? Is it paraflu? Or is it streptococcus pneumonia that needs an antibiotic? So, and it's cheaper to give the antibiotic than to do a diagnostic test. So I think the worry about the COVID pandemic is by default, by increasing respiratory disease in the communities, by default, the expectation is that the prescription of antimicrobials, especially when the access to healthcare systems existed, that will take place, quote unquote, just in case they have an infection, a bacterial infection. We are not saying not to use antibiotics for COVID patients, but the WHO has released guidance on how to use antibiotics in COVID patients, definitely not for mild cases within the community, but after a risk assessment or assessing the patient for a super infection or for a differential diagnosis prior to getting the COVID infection. So it gets a little bit tricky there. What I do want to say is that the role of nursing in the COVID pandemic was extremely crucial. And the leaders of infection prevention and control are usually nurses or microbiologists. It's very rarely that you have people like me who are infectious disease physicians who dive into infection prevention and control, or internists or pediatricians who are generalists to do this. So the core role that nursing and midwiferys can play is to ensure that the proper care is given from the nursing perspective when it comes to mobilizing the patient, taking care of their wounds, their IVs, and even guiding the junior physicians. I learned my best techniques from our senior nurses when I was a resident in training. So I think they have a critical role in ensuring that the ship is sailing with the right performances and practices for the betterment of the whole community.
Fantastic.
Thanks, Hanan. So I know we need to get down to the nuts and bolts of the challenge itself. But for those who are asking questions, we've gotten a couple more in the Q&A, which maybe if Hanan has time, she can type a few short answers to. But I want to assure everyone that I believe that we are planning a technical webinar that will go into all things AMR in the coming months. And so thank you so much for all of the interest and the questions you have. And Emily, I'll hand it over to you for all the important details that are coming up.
Thank you very much, Leanne, and thank you so much, Professor Buckley. That's absolutely brilliant. And it just says to me there is so much more that we need to be talking about. And just as the questions are getting going, we're going to save them up and put you in the hot seat again another day. So thank you so much. But just before we stop the questions, I just want to go back to Elizabeth, actually, and ask you a question, Elizabeth. Much of what we're talking today and what we're asking people to do is to step into roles where we need to be leaders as nurses. We need to take roles and lead. And you speak frequently about the need for us to be leaders in nursing. The strategic directions for nursing and midwifery focuses and emphasizes hugely the need for us to be nurses, leaders. Can you give us your thoughts on how nurses need to be leaders in tackling AMR?
Thank you, Emily. I think for me, as I've always said, leadership is not always at the top. Leadership is at various levels of where we practice. And I think, within the AMR aspects of nursing and midwifery, I think you will find opportunities where nurses play really significant roles because of patient care. I think Hanan made references to some of these elements, and their practice around doing assessments of patients, around diagnosis, nursing diagnosis, supporting the provisional diagnosis that doctors have. And we also have nurses who have prescribing rights, and so have extended themselves in terms of development of patient-specific treatment plans. So I think there is definitely the opportunity that they have to influence antibiotic use and the prescribing rates at various stages of a patient care. So I think the main thing around leadership, I think, in this area is about the opportunity to change people's behavior. So not just necessarily within the hospital setting, but also outside the general community and primary health care. So I think, communications around education and just raising the awareness that goes beyond just educating, giving information on health and hygiene related challenges. So it's about, again, the reference to antibiotic misuse and overuse, to poor environmental sanitation and personal hygiene. So I think these are core elements of nursing practice. So I think, leadership is about then enhancing those principles. And I really kind of encourage those that are listening into our conversation today and the expertise that's been shared by Hanan. I think it's really in positioning nurses in practice, in research, in academia, to really step up in terms of how we make that influencing approach to our patients and to the people in general community. Thanks, Emily, for the question.
Oh, well, thank you for the answer. That's much more interesting. I think it is really important. And I think leads really beautifully into talking a little bit now about the challenge itself and what we are asking you to do. So as Elizabeth said, the challenge is, in your role as a nurse or a midwife, develop a solution that tackles misuse and overuse of antibiotics. Sounds quite simple, but I think when you take the discussion that we've had and had the opportunity to listen to today, there are so many avenues for this that I suspect the difficulty be, which one do you take? I think we've heard about the environment, we've heard about good communication, the need for education, taking good history, taking observations of our patients, something that you may not consider hugely significant, but actually is massively important. And of course, the roles that we all play in leading and teaching and supporting patients, their families, and our colleagues. So huge amount of opportunities for this challenge. And just a little bit of information about what to do next. So have a think about reflect on the sessions that you've heard, think about the questions that you have more questions to ask us, please save them up. We've got more opportunities to discuss this further. We will be holding another webinar on the 17th of March, where you can hear more from our AMR experts. It'll be a little bit more technically focused, and we're delighted that we'll have the AMR team with us again on that day. Then again, we're going to have another session on the 6th of May when we're going to hear from you. So our team at the Nursing Now Challenge will be seeking some of you to talk about some case studies and some experiences that you have around this issue. And we'll be hearing your experiences of them and being able to discuss and talk about your solutions and how you manage those situations. So looking forward to that session very much. And we'll be in touch with some more information about that. And then we come to the final session, which we're going to be hosting in June the 22nd, when by then we hope that you will have submitted your solutions to the Nursing Now team. We will have reviewed them, read them, and we will select what we consider to be the most wonderful top 3, and we will like to be able to hear from those top 3. And during that session, we will announce the solution that we think has won our challenge, and delighted to say that the Nursing Now team will be offering £1,000 to support the implementation of the solution that you suggest. And at the same time, we will be offering the winner or the winning team a chance to present their solution to the senior team at the WHO, and to really get insights and support from the team there in how we can make this a reality. And I think this is massive for any nurse or midwife anywhere, to be able to come up with a fantastic solution and then put it to the most extraordinarily amazing experts in the world is not something that we will ever get the chance to do very often. So I think it's a wonderful opportunity to be able to put your idea and to ask for support to do that. We also want to help you, support you to publish your solution, and we'll be working with you to develop that in a journal so that we can share your solution with people all over the world. So some really, really awesome results we hope that we will get to through the next few months. What we ask you to do now is to put your, if you go to the Nursing Now website, you can see there the details of the challenge. So it'll talk to you about what they want you to write, how they want it to be presented, information about you, really tell us why you thought of your solution, what's your experiences that have led you to your solution, what are the resources that you need for your solution to become a reality, and really give as much detail as you can about why you think your solution will make a massive difference to the global challenge of antimicrobial resistance. So the resources are all going to be available to you on the Nursing Now Challenge website. We also at WHO have a global community of practice. Some of you I know have joined it already. The details of that I think we're going to put into the chat box now, but you can join the community there, and you'll also find in one of the groups all the information. You can re-watch this webinar, and we'll host all the other ones there over the course of the next few weeks. So several places where you can find information and resources that will help you. There's also an opportunity to ask questions. There's a Facebook group we encourage you to join. But the first point of contact would be go to the Nursing Now Challenge website, where all the information and resources are there for you. So I think if no one has any more questions about the actual process, I can't see any in the chat box. I'm going to say thank you very, very much to our speakers. I think we've kicked off something that's going to be really, really special, really important, and will have a massive impact. So good luck with everybody who's going to put their heads down and think of something. We are really excited to see what you come up with. And I'm going to hand over to Elizabeth just for some final remarks, Elizabeth, before we close. And when we do, it's not forever, because we'll be seeing you again in about 3 weeks' time. So just over to you, Elizabeth, for your final remarks.
Thank you very much, Emily. I'd kind of really like to take this opportunity to close off by thanking Professor Hanan Balki and Leanne for your time and for your enthusiasm to engage and to really share this inspirational opportunity with us all, with the Nursing Now Challenge, and with the individuals that have joined us today. I think, we've already seen the film that was shown was developed by students. So there's again another opportunity here for our young career nurses to also take up this challenge to showcase to us what innovative ways nurses and midwives can actually contribute to the agenda. I think, for me, some of the key messages that came across, Hannah, is about how are we nurses and midwives going to keep our patients out of hospitals? How are we going to keep them in the communities? So I think those are really key elements. So how do we influence those changes is something that's kind of came across quite strongly for me. And of course, the technical aspects to it were actually laid out. So thank you very much for that, for highlighting what more we could actually do. And so again, I do look forward to seeing these proposals come forward. And Emily, thank you very much for moderating, and to the Nursing Now Challenge team. Really appreciate this collaboration. Look forward to our next meet. Thank you very much.
Thank you, Elizabeth, and thank you all for joining. I think for sure nurses and midwives around the world have always stepped up to challenges, and we've seen that more than anything in the last two years. So here is one more, and we really look forward to hearing what you're going to do next. So thank you for joining us, and we'll see you again on the 17th of March.
Thank you,
Thank
everybody.
you.
Have a great day. Thanks, Elizabeth. Thank Emily.
Thank you very much.
Thank you to the nursing discipline. Love you all. Bye.
Thanks, Hannah. Bye all. Thanks, Emily.
Bye. Thank you.